Welcome back, everybody. Hopefully everybody is calm, rejuvenated, and ready for our next session. We are so thrilled that we are going to now hear from a parent who turned her experience as a NICU mom into a commitment to advocacy. And we will also hear from Dr. Susan Wang that will share more information about the Define program and how it's working to change how we think about engaging parents in our NICUs. I want to first introduce you to Emily Fawaz. Emily lives in Fort Collins with her amazing husband, 3 wild and loving kiddos, and 2 incredibly tolerant dogs. She's an occupational therapist, but is currently staying home to care for her 3 boys, ages 2 and under. Her oldest 2 kiddos are twins, born at 28 weeks at Children's Hospital in Aurora. During their 4-month NICU stay, as well as the months that followed discharge, Emily developed a strong passion to support and advocate for fellow NICU families. In the moments between diaper changing, meal prep, laundry, park trips, reading the same book 100 times in a row, setting up Hot Wheel ramps, and the best triple snuggles ever, she participates in various programs to support NICU families, including the Define program, the NICU Consortium Partnership, Love for Lily, and Parent to Parent of Colorado. As life allows, Emily also plans to continue to support NICU families in a professional manner as an occupational therapist in early intervention.
Thank you so much. I'm thrilled to be here and be able to share my story with all of you. Our NICU story starts with our very first ultrasound at 8 weeks. That's when we found out we were having identical twins. They were mono-di twins, meaning they were sharing a placenta, and they're at risk for developing twin-to-twin transfusion syndrome. So starting at 12 weeks, we had ultrasounds every 2 weeks. And for the beginning of the pregnancy, every time we went in, things looked great. And besides, there being 2 of them, it was a pretty uneventful pregnancy for me, up until my 28-week appointment. And so my parents were in town because my husband, Dylan, was down in Fort Carson for military training. And I thought it'd be fun for my parents to see the boys and get to see an ultrasound. But almost immediately, it was clear that things weren't good. There was a really large fluid discrepancy, and it was clear that they were developing TTTS. And so my OB called down to Children's, and I had an appointment the next morning there. And my parents, we came back from my OB's office, and I had to make the hardest phone call of my life to Dylan to tell him that he needed to come home and that things weren't good, and that I would likely be admitted to Children's the next day. The next day we went down to Children's, and they were diagnosed with stage 3 TTTS, starting to show signs of stage 4. And stage 5 is the death of one or both of the twins. So it was a pretty severe case. We were told that I'd be admitted for continuous monitoring and get 2 doses of steroid, and with the plans to deliver about 48 hours later. Mason was our donor twin, but he had different plans for us. That the next day, I started having severe contractions at like 1 in the morning. So, less than 12 hours after being admitted. And by 3:30, he was having consistent late decels. And so I had an urgent C-section, and they were born less than 30 minutes later, just before 4 a.m. And between that first 28-week appointment with my parents and the boy's birth was 43 hours. So, calling it a whirlwind is a complete understatement. And so, after the hustle of getting into surgery and then being born, I got to peek at them as they were being wheeled to the NICU. And then I went back to my room to recover. And once I was settled, Dylan and I both said, no, he should go see the boys, go be with them. And besides, my parents weren't there yet. So besides the nurses doing their checks, I was all by myself. And I didn't realize how much that moment impacted me until I was preparing for my C-section with my 3rd son, when I was sitting in my OB's office crying over the thought of not getting to hold him or having him taken away from me, because I was still feeling that pain from the first hours and days of the NICU. It was 3 days before I was able to hold Mason, and it was a week before I was able to hold Ryan. And I didn't get to go see them. It was about 5 hours until I got to go touch them for the first time. And so just to give you first like a snapshot of their kind of medical journey in the NICU, Mason, he kind of kept us on our toes from the get-go with an unplanned extubation when he was just 4 days old while I was holding him, which triggered them to call a code, and it took 3 attempts to reintubate him, and it was awful. And then 24 hours later, he was taken to the OR for emergency surgery for a bowel perforation. And then over the next he came back up with an ostomy, which he had for 8 weeks. But in between that time, he kind of went back and forth from high flow to CPAP, high flow, and it was just, that roller coaster that everyone talks about. Following his surgery, which went well, he developed an infection in his blood and his lungs, which set him back in his respiratory progress. And we started having the beginning discussions of potentially him needing a trach and a G-tube. But we did one final round of steroids for him, and he turned a huge corner and weaned down to low flow and discharged about a month after his due date. Meanwhile, Ryan, he was our twin A, our recipient twin. He took a couple steps back with his initial attempt to extubate on his second day of life. He ended up on an oscillator for about a week, but then after that, he made a big recovery and just steadily weaned down on his respiratory support to low flow by around 34 weeks. And then he was kind of that typical feeder grower for us and discharged in mid-October, so right around his due date. In terms of the experience as a parent in the NICU, which is what I'm focusing on today, the NICU was the most challenging and devastating and transforming experience of my life. We were there for 114 days before we finally went home. And during that time, I only went one full day without seeing them. And while it was incredibly exhausting to be there for 12 to 18 hours a day, every single day, I feel very fortunate to have been in a situation that allowed us to do that. We stayed at the Ronald McDonald House. My husband was able to work remotely for the majority of that time. And I was working at the time at the hospital up here, but I was able to not work so I could be there. But even despite being there all the time, we still had to leave. And when you think about becoming a parent, you expect to be with your baby all the time. So when you're away from them, it's a very strange feeling of wondering, am I actually a parent? Is this real? Are those really my kids? And like I said, even though we were there every day, it was really hard to feel that bond with them. At the time, I thought that I was bonding with them. I cared about them and I worried about them and I spent every day with them, but I didn't realize how long it took me to actually bond with them until I had my third son and realized how quickly I was able to bond with him compared to them. And, that's not necessarily surprising, right? Well, I was excited to see them, my boys, for the first time, the twins, and touch them and hold them. It wasn't what I had hoped for. It wasn't what I dreamed for when I thought about becoming a mother. There are wires and alarms going off and there are tubes. And while they're cute in their own way, they're not this chunky, peaceful newborn that you imagine getting put on your chest minutes after they're born or seconds after they're born even. All I wanted to do was hold them and snuggle them and nurse them, but I couldn't. The first few days, all I could do was cup their head and hold their feet with my arms in the isolette and stand there with swollen, tired feet, pain in my stomach from my C-section, and tears in my eyes. And honestly, standing there, I didn't, sit down because I was tired. I would finally walk away when my heart was just too broken to stand and look at them anymore. And then, a few days in, we finally got to hold them, and it was so wonderful. And those moments of finally getting to kiss your baby and see them on your chest after days of waiting were so sweet. And I will never forget those moments. But then, those days that you're there turn into weeks, and the weeks turn into the months. And despite us being there all day and having that time to be involved, some days I didn't even want to hold them. I didn't want to sit there all by myself with the deafening sound of CPAP in my ear, staring at the monitor in fear that they will Brady, and just sitting there for hours on end. You know, I just wanted my life to be different than it was. And I felt so much sadness and guilt every day. I felt guilty when I didn't want to hold them or when I didn't want to be there, or if I felt like those feelings of doubt, like, are these my children? And I felt guilty if in a day I only had time to hold one of them. So some days, if that were the case, I just wouldn't hold either of them because I just couldn't pick which boy I should hold. I'm a very type A person. I like routine. I like getting into the groove. And I had a really hard time figuring out a good schedule for myself that worked around care times and pumping every 2 through 3 hours and getting time for me and getting to be involved. Getting to like being available for rounds and just like trying to make the day work out for me and make it survivable. And you know, the nurses and the providers, they encourage you to be involved and to advocate for your babies. And I definitely did. And I was there for rounds almost every single day. And, you know, in rounds, while I absolutely felt that my thoughts and my opinions were heard and considered and validated, I definitely did. I mean, overall, at the end of the day, we were not in control of their care. And that's not necessarily a bad thing. You know, I can't emphasize how in awe we were of the care and the skill of the whole team that took care of our boys. The NICU specializes in growing these babies and getting them home, and thank God, because that is way beyond my scope as a parent. But at times, it didn't really feel like they were my kids, you know, my boys. I felt like they were babies that, you know, while following strict rules on how to care for them, I was supposed to love them deeply and devote my time and energy to them with the hopes that one day they would be big enough and strong enough to come home, and then they would be my babies. But they weren't really mine yet. And I am so wholeheartedly thankful to the bedside nurses who helped us to slowly overcome those feelings. Our primary nurses were the shoulders that we cried on, the ones who could make us feel like parents, because they helped us to see past the lines and the monitors and the tubes, and they would tell us how sweet and adorable our boys were, even when our family and friends were too afraid to even touch them. You know, that's just another thing that you grieve in the NICU. You look forward to holding, you know, you don't get those first moments as the parent, and you also don't get the moments of getting to watch your parents or your friends hold and love on your baby. You know, our parents didn't hold our boys until they were 3 months old because they were so afraid to hurt them and to hold them and to touch them. So, you know, you try to love your children when you're in there, and you worry about them constantly, and you convince yourself that you really are their parent, while at the same time you release control of their care to other people. And that is so unnatural. And I feel like many providers in the field, they know that, and they know that parents are having to do that. But the way that that tension feels in your heart is something that I believe can't truly be understood unless you've been there. And while I was in the NICU with them, I was able to connect with another NICU family in a similar situation. And I also had a mentor through Children's come to meet with me. And I was so grateful for those connections, because often those conversations with strangers were way more powerful and reassuring than conversations with even my closest family and friends. Our family especially, they really didn't want to see us hurting, and they wanted to try to say something to make us feel better. But we were hurting, and there really wasn't anything they could say to make the pain and sadness go away, unless there was some magic word that would make them big and ready to come home. It's just hard. Like, being there is just hard. And every single day was so hard. When Mason was still admitted, and he was ready to go, we fought to be discharged on a Friday night instead of a Saturday morning, so that we could have the whole weekend together as a family before my husband went to work on Monday. And we were asked you've already been here for this long, 114 days. What is one more day? And while I can understand why they would think that, what they need to understand is that it never gets easier. It's not just one more day. It's another day of being away from home, another day of suppressing your parental instincts and letting other people be in control of your baby. Another day of not getting to snuggle up on the couch and just be together as a family because the cords don't reach that far. And another day of walking out of those hospital doors without your baby. That, like I said, that feeling is so unnatural and it never gets easier. And I would say that it gets harder and harder because as you do start to become more attached to your baby and bond with them, it hurts so much more to leave them. The beginning of the experience, those first several weeks, that was mentally exhausting. It was like an adrenaline rush every day of hearing alarms and, oh, they're breathing again. Oh, their heart rate dropped. Oh, we're bagging them to get them to breathe again. Like, it was just constant and scary, but it was mentally exhausting. Like I said, like running on adrenaline. But as you settle in and they do start to grow and get stronger, it transforms into this heartache of just wishing that you were home. And like I said, you're just so much more attached to them and you're just feel like this time is passing and you're missing all of the sweet moments that you dreamed about. And so, yeah, the end is not easier than the beginning is what I can say about that. So, but we did fight that last fight and we discharged in the evening on Friday, November 15th. And it was one of the sweetest days of my life. We'd watched so many families walk by our room with their wagons and their sweet kiddos and leaving the NICU for the last time. And we imagined how wonderful that moment would be. And I wanted that moment to come more than anything I'd ever wanted in my life. And it felt like it would never come. It felt like we'd been there forever and we would just be there forever. But then it did come. And I remember that whole evening like it was yesterday, loading up the boys in the car seats, walking out of the NICU doors, riding in the glass elevator, going out the doors of the hospital and getting them in the car. And while that walk and driving out of the parking lot was so familiar because we'd done it 100 times, we were finally doing it with both our boys and we were actually going home. And we arrived at our house to balloons and signs and a big group of friends playing The Boys Are Back in Town, just ecstatic to welcome us home. And it was just, I'll never forget that day. It was one of the best days of my life. You can go to the next slide. But our NICU journey didn't end there by any means. And while it was so sweet to be home, it was also really hard to take on the role of caretaker that a whole team managed at the hospital. And now you're supposed to be doing this on our own. We had so many appointments, I think 15 in the first 4 weeks, and very little sleep. I think we were getting like 2 hours total the first couple weeks we were home. And it was really hard, but we also made a really strong effort to choose to find the joy and appreciate those moments with them because we knew it was very close to us that not everyone gets to bring their kids home from the NICU, and we did. And we are eternally grateful for that. Over the past 22 months since being home, we have had the pleasure of watching these incredible boys grow and develop into hilarious and sweet toddlers. It is not easy, and being completely overwhelmed is just a regular part of my life. I often explain that we just have a much higher baseline of chaos in our house at all times. But a day does not go by that I don't appreciate and admire how far they've come. You can go to the next slide. And as if our life weren't busy enough with 2 toddlers, we were blessed and also surprised to find out that we'd be expecting another boy. And he arrived just 17 very short months after our twins were born. That pregnancy could not have been more uneventful, and he stayed put until my scheduled C-section at 39 weeks. And he was, from the time he was born to when we left, was 48 hours. And getting that experience, that typical experience that people dream about, was such a blessing and a joy. But at the same time, it was really hard because it made me realize just how much I had missed out with our boys. You know, and when I think about our NICU journey, I hope that the hardest part is behind us, but the impacts of their prematurity on their life are not behind us quite yet. Both boys have been readmitted to the hospital for respiratory viruses. We've stayed isolated for the past 2 years to keep them healthy for the most part. They both receive weekly therapy and still have some catching up to do developmentally, but overall, we are just so proud to be their parents. Well, I wouldn't choose to go through the NICU again and wouldn't wish that experience on my worst enemy. I am also so grateful for what we have learned about our kids and about life in general. I'm grateful for the strength that Dylan and I have gained as individuals and as parents and in our marriage. And I'm also grateful for the way that my life trajectory has changed and for my growing passion to help other NICU families. Families in the NICU are experiencing a weight of pain and fear and grief that is hard to even fathom. It is lonely and heartbreaking, even on the best days. And while we may never be able to take away that pain completely, I wholeheartedly believe that supporting parents and connecting them with other NICU families, both during and after their stay, will not only lighten the burden of the NICU, but also have lasting impacts on the family in the weeks and the months and the years to come. I could talk about my experience for hours, but I just thank you so much for this opportunity to share my story with you all today.
Emily, we want to thank you. It takes a lot of courage to share your experience. And so thank you. And it takes a lot of resilience and to also want to advocate for other families after going through such a challenging experience with your NICU stay and continuing, you know, to support your children with ongoing medical issues, like you said, long-term. So thank you for being a patient partner and an advocate and a voice for many other families. And with that, I want to introduce someone that, Emily, I know you know very well with your work as a patient partner, but would like to introduce to the audience Dr. Susan Wang. Dr. Wang is an associate professor of pediatrics at the University of Colorado School of Medicine. She is the Lula O. Lubchenco Chair in Perinatal Medicine and is a neonatologist in the NICU at Children's Hospital Colorado and University Hospital at the Anschutz Medical Campus. She is the NIH-funded perinatal health services researcher whose work focuses on the transition of high-risk infants from hospital to home and optimizing parental engagement for medically vulnerable infants. Dr. Wang is also passionate about state perinatal quality collaboratives. During her time in Massachusetts, she formed and led the Massachusetts Hospital Safe Infant Sleep Quality Improvement Collaborative. Presently, she leads our Colorado effort to improve care of opioid-exposed newborns, as well as the collaborative focused on improving family engagement in the NICU. Dr. Wang is also the vice chair of the Colorado Perinatal Care Quality Collaborative, and we are so extremely fortunate, and I cannot say that with enough passion. We are so fortunate to have her as one of our team members and provider partners. Dr. Wang, pass it on.
Thank you so much for the warm introduction. And Emily, thank you so much for sharing your story and your experience with us and the broader perinatal community in Colorado. While, as many of you know, I focus a lot on data, but it's really those personal experiences that impact us, I think, most profoundly and certainly motivate us and inspire us to continue to do this work. And so today I'm really excited to share with you a new quality collaborative that's called Define Colorado, and that stands for Data-Driven Engagement of Families to Improve the NICU Experience in Colorado. Next slide. I have no conflicts of interest. And so when we talk about family engagement, parent engagement, I think we all have a sense of what it means. It's all that stuff that Emily just talked about, all of those adjectives, verbs that she associates with parenting, with mothering. But when we take a step back and think about how a healthcare system might define it, it gets a bit more difficult. So there are lots of definitions out there, but I really like this one from AHRQ, which says that patient and family engagement are a set of behaviors by patients, family members, and health professionals, and a set of organizational policies and procedures that foster both the inclusion of patients and family members as active members of the healthcare team and collaborative partners with providers and provider organizations. So truly, it's centering the patient or the family within the healthcare system, and it's change that occurs at the individual, organizational, and system level. Next slide. Now, the other issue that we have about quote unquote engagement is how should we measure it? How do we define it? And I'll be honest with you and say that there is no validated measurement that is widely accepted in the perinatal community for engagement. And many of us think about it in the following ways: time spent in the NICU, parental presence on medical rounds, a parent understanding their infant's medical conditions, comfort and proficiency of parents with infant care. And is it just parents? What about grandparents and other caregivers that will be involved with infant care once that family is discharged? And so there's lots of ways that we could potentially measure it. And like I said, no one way has been fully accepted. Next slide. That being said, however we define it, we know that it's impactful and effective. I'm going to share with you the largest randomized clinical trial that's been done focused on family engagement. It's called FICARE, Family Integrated Care. It was a cluster randomized trial that included NICUs from Canada, Australia, and New Zealand. And they randomized preterm infants to receive family integrated care versus standard. And this family integrated care involved the primary caregiver committing to a minimum of 6 hours per day of infant care during the day, and really involved with every aspect of infant care practice. They followed a number of primary outcomes as well as secondary outcomes. And while some of these numbers, for some may be meaningful, I think when we hear from the investigators directly, I think it really brings home what this effort was about. So if you can please play that segment. And the person speaking is Karen O'Brien, who is one of the principal investigators.
The philosophy of family integrated care is that families should be allowed to participate to the best of their ability in the care of their infant, even when their infant is sick. And that can look different for different families. It can look different for different hospitals, depending on what supports they have available for parents. But the idea is really to support parental presence and parental engagement in their baby's care. The results of the pilot study were able to demonstrate that the parents actually had less stress when they were in family integrated care. The babies grew better when they were in family integrated care. There was less nosocomial infection. There was less retinopathy of prematurity, in fact, in the babies who were in family integrated care. And this makes sense to me. Parents being at their baby's bedside will actually both protect the babies from infection and decrease the risk of there being errors at the baby's bedside.
Great, thank you. Go back to my slides. Next slide. So here are the results. So this randomized cluster trial randomized nearly 900 infants to FICARE versus almost 900 to standard care. And what you see here are their primary and secondary results. We see that in the FICARE enrolled infants, weight gain was better at day 21 of hospitalization. Average daily weight gain was better. They were more likely to be exclusively breastfed at discharge, and parental anxiety and stress scores were lower compared to the standard group. Next slide. And so if we know that family integrated care has a positive impact on babies and their families, well, why aren't we doing it? What are the barriers to optimizing parental engagement? So I'm going to give you a few of the local barriers that we encounter here in Colorado. The first is our wide catchment area. Our babies come from all over the Rocky Mountain region. So this is data from a study done by Stephanie Bork, one of our junior faculty members. And she wanted to look at the prevalence and predictors of back transport after acute care in our level 4 Children's Hospital NICU. So shown here are the areas where our infants were admitted from, all over the country, mainly the Rocky Mountain region, that came to our level 4 NICU. Next slide. And so this shows predictors of back transport. So among those babies that in fact recovered in our NICU and were able to be back transported closer to home, what were some of the factors that were associated with that baby going back closer to home? And we found that, I'm going to really highlight this one point, and that was insurance status. That families that were publicly insured were far less likely to be back transported closer to home than our privately insured patients. So clearly things that we can be thinking about at local as well as at policy levels to better support our families. Next slide. In this study, first of all, there was only a small fraction of babies that in fact were back transported. So the majority of those babies, after they had recovered from their acute illness, remained in our level 4 unit. And when we look at the median length of stay for how long those babies were in our unit after achieving clinical stability, it was 28.5 days. So nearly a month that these relatively well babies were in our NICU, far from their parental residence. Next slide. So back transport, the lack thereof is a barrier. The second, let's talk about parental primary language. So this was a study conducted by Mauricio Palau, who's a neonatologist at Denver Health. And he wanted to understand the impact of parental primary language on communication in the NICU. He compared Spanish-speaking families and English-speaking families. He recruited families from 2 NICUs at Children's Hospital Colorado, as well as our university NICU here at the Anschutz Medical Campus. And he worked directly with families, surveying parents directly, and asked them a series of questions. One was to ask them what was their infant's diagnosis? What was the reason that their baby was admitted to the NICU? And what he found was that fewer Spanish-speaking parents were able to correctly identify the reason that their baby was in that NICU. And even after he controlled for education, recognizing that our Spanish-speaking families had somewhat of a lower level of education, even with that, even accounting for parental education, Spanish-speaking families were far less likely to correctly identify their child's diagnosis. Next slide. Moreover, when the Spanish-speaking families were asked how they were communicated with by their provider team, this is how they responded. And so shown on the left are responses for nurses and then physicians on the right. And you can see that among Spanish-speaking families, they report that both nurses and physicians, the majority of these providers, speak to them in English. Next slide. So clearly, primary language impacts parental knowledge, communication, interaction in the NICU system. This study looked at 4 different NICUs in the Colorado area. We followed and recruited nearly 200 maternal infant dyads from 4 units to assess how their level of engagement impacted other outcomes further down the line, but also to understand what were some of the factors that impacted their ability to even be engaged in the NICU. Next slide. And so here engagement was defined as sort of number of days per week that a family was able to be in the NICU. So shown in the dark line is the group that was able to be in the NICU for 6 or more days per week. And then in the dotted line, those families that could only be in the NICU less than 6 days per week. And so I show you this because you could see where that drop off starts to happen and where there's separation of the number of days per week that mothers can be in in the NICU, that perhaps in that first week after hospital admission, pretty close, 6 to 7 days, nearly every day of the week. But very soon thereafter, there's this separation, with some families being able to be there almost every day, others much less likely so. Then finally, the week before discharge, you can see that both groups kind of come together at around 3.5 to 4 days. And many would say that the week before discharge is a bit of a nutty time with lots of education that occurs. And perhaps that shouldn't be the model of transitioning care, but the reality is that that in fact is what happens. And yet the least amount of time in the NICU is spent during that week before discharge. Next slide. And so what were some of the factors that were associated with maternal time in the NICU? And what you could see here is things that we already know, but yet this was one of the first studies to clearly identify it. And you could see that families that had a higher household income greater than $100,000 per year, had a shorter travel time to the NICU, and who did not have other children to care for, those families were much more likely to be able to spend 6 or more days out of the week in the NICU. Next slide. And so clearly there are a whole host of factors that are associated with families' ability and ability to be present and then engage in the NICU. But what's remarkable is that the majority of them are social determinants of health. We identified in those prior studies: distance, language, race, ethnicity, insurance. And so for that reason, we clearly recognize that in our state, there was a need to optimize family engagement and standardize our approach across NICUs throughout the state, and hence Define Colorado was formed. Our aim statement is as follows. It's twofold. The first is that we want to improve parental report of engagement in infant health and development during NICU hospitalization by 20%. Second, reduce disparities in parental report of engagement by race, ethnicity, primary language, and distance from the hospital by 20%. Our primary drivers, which is what I'll mainly focus on here, are fourfold. One is improving communication between NICU staff and families. The second is offering social and financial supports for families to enable engagement and presence. Third, optimize family engagement in hands-on NICU care. For this, we're focusing on skin-to-skin breastfeeding. And then lastly, having families actively participate in discharge planning. And for all 4 of these primary drivers, you'll see that the secondary drivers are those social determinants, those social factors that we highlighted in the earlier studies, that we're really thinking about language, offering social services, optimizing communication, having shared decision-making. And so it's not necessarily clinical, bedside, typical quote unquote medical care, but it's really these other broader factors that we need to address to optimize family engagement. Next slide. And so what I want to highlight is unique about Define versus some of the other quality improvement collaboratives is that first, our primary aim is based upon data that we collect, not from the electronic medical record, but parental report. So you can see here that we want to improve parental report of engagement in infant health. The second piece is that we are, as we heard from Dr. Gillespie-Bell, adopting a health equity framework right at the outset. And so we're not doing a post hoc analysis of our data stratified by race, ethnicity, no, but from the very outset, our aim is to reduce disparities in parental report of engagement by race, ethnicity, primary language, and distance from the hospital by 20%. Next slide. And so for this effort, we will have a centralized data system, and there are some eligibility criteria. And so for infants and families to be eligible, they have to be admitted to a level 2, 3, or 4 NICU in Colorado. That infant has got to be admitted for at least 14 days. There's no restrictions on parental or caregiver presence during the hospital stay. And for large volume centers, we recognize that capturing data on every single admission that fits this criteria may not be feasible. And so therefore, the first 15 admissions who meet criteria would be entered into our data system. Next slide. Our data system is a centralized REDCap data system that's housed within the University of Colorado School of Medicine. For sites to participate, there's got to be completion of a business associate agreement, and that really applies for non-children's affiliated and non-university affiliated sites. For the children's affiliates and university affiliates, we've gone through all the regulatory rigmarole, and so you won't have to do any of that. You would be eligible to participate. Our data will include the majority, the most important parental surveys, as I mentioned, but we will have some data abstraction of patient-level electronic medical record data. We will generate quarterly reports for individual NICUs and then for the entire collaborative as a whole. Next slide. So this is what our parent survey protocol will look like. And so within the first week of infant admission, you think that that baby likely will be there for at least 14 days. So the hospital team member would inform the parents about this effort and ask permission to send mom or dad a survey by email or text after 2 weeks of admission. Once parental permission is obtained, then the hospital team member creates a REDCap record and generates a parent ID. And then about 2 to 4 weeks into the admission, the team member then abstracts some clinical and demographic data from REDCap. We also have parent email address and phone number, et cetera, at this time. And here we send parents their first survey. Next slide. The second parent survey is sent around the time of discharge, ideally within about 48 hours. And the final survey is sent about 1 month post-discharge. Now, the survey covers a range of topics. Importantly, obviously, we'll have some measures around feeling engaged, included in the care of their infant. We'll have questions specific to communication amongst providers, questions about breastfeeding, skin to skin, as well as safe infant sleep, and then maternal mental health questions, as well as questions around financial strain. Next slide. So we talked a bit about the business agreements. As I mentioned, for the university and children's affiliated sites, you really don't need to do anything at all. We've done all the hard work here at the main campus. And then for other sites, it would be a business associate agreement process. And we are well versed in this, and we're more than happy to help you. Next slide. And so now I wanted to share with you a few of the sample interventions that are available in our toolkit. So the first comes to us from Dr. Meg Kirkley at Denver Health, and this is an intervention that she developed called DPOC, discontinuation of pulse oximetry checks. And so as neonatal providers know, I think we sort of obsess about our monitors in our NICU at the bedside, especially our pulse ox. And so oftentimes what we've recognized is that even when the babies are well, not having Brady's, not having spells, we're still kind of fixated on that monitor. Even when we know, oh, that pulse ox probe is not on the right place, the recording is not good, but we still fixate on the dings of that monitor. And certainly the families are quite anxious about what that number says. And so for that reason, Meg really wanted to optimize that family-infant interaction, particularly around feeding, so that families are focused on their baby's cues more than that pulse ox. And so therefore, she developed this project that will increase the percentage of eligible infants, so medically stable infants, who instead of getting continuous pulse ox, just get intermittent pulse ox checks during the day, so that both the bedside nurses and the families are not perseverating about the pulse ox, but really focused on the infant. Next slide. Next slide. Second sample intervention comes from the Children's Hospital NICU from Stephanie Bork and Elizabeth Shireholtz. And this really focuses on discharge readiness and starting discharge education as early as possible, and including families at the outset around discharge readiness. And so this is a very standardized approach so that there's not variability from nurse to nurse, provider to provider, depending on the timing of discharge education, as well as the long list of items that need to be covered. And so very standardized approach to discharge readiness teaching of families. Next slide. The next intervention comes to us from St. Joe's, and I would say the St. Joe's NICU, they are really at the cutting edge. So I talked a lot about family integrated care earlier, and St. Joe's truly is the only NICU that I know of in our state that has integrated PHI care into their clinical care. And so they have their own PHI care program in place, and they report that their goal is to work in partnership with parents to create a consistent and nurturing environment where parents feel engaged, enabled, educated, and empowered as the primary caregivers for their baby. Next slide. So at St. Joe's, families that are involved in FICE care do the following. They're involved in feedings, diaper changes, obtaining vital signs, bathing, giving oral meds, participating in medical rounds. They even do charting, keeping record of infant care from day to day. And so truly they are the center of their medical team. Next slide. The Parent-to-Parent Partnership Program is another program at Children's Hospital, and we heard about this from Emily. You know, it's a program that optimizes the experience of families that have had the experience of either prematurity or medically complex children in our hospital system. And so they would like to ensure that parents and families have a unique support system beyond just the clinical care providers in their unit. Next slide. And so in this peer-to-peer support program, a peer parent partner offers some amount of psychosocial support, resource navigation, self-management. And you heard exactly that from Emily, you know, coping strategies and impairment. And to hear from another parent who lived through the experience, as you heard from Emily, is so much more powerful and connecting than getting sort of advice and support from a clinical care provider that has never gone through that experience themselves. Next slide. And within the DEFINE program, we've had opportunities to think about, you know, studies, novel approaches to better understanding what families' truly needs are. And so this is a study that's been undertaken by one of our neonatology fellows, Dr. Tina Ramo, and she wanted to better understand what are the barriers and facilitators to communication with our families in the NICU. You saw that in our primary, one of our primary drivers in our key driver diagram is really focused on communication. And yet, I don't think we have a good understanding of how parents want to be communicated. The timing, the frequency, the content, any of that. I think we know, but I don't think we really know. And so Dr. Ramos seeks to conduct this qualitative study to interview families to better understand their experiences and preferences around communication in the NICU. Next slide. And then finally, the last example that I'd like to share related to the DEFINE work is what's called the SPROUT program. SPROUT stands for Supporting Preemie Respiratory Outcomes Transitional Team. This also comes out of our Children's Hospital NICU. And what Dr. Erica Mendel shown here recognized was that families of extremely preterm infants that have the severest form of chronic lung disease have unique experiences and needs that are even different from families of other preterm infants. Their length of stay is much, much longer, and their time in the NICU is quite traumatic at times. And so what families were telling us anecdotally was that there was so much inconsistency in the care that they were getting, depending on which provider was there, as well as inconsistency in communication, and that was contributing even further to the stress and trauma of being in the NICU. And therefore, this program was started so that we could standardize our care and also center families in the care of these very complicated babies during their NICU stay. And so truly this is family-centered care with a core group of providers that maintain consistency throughout the hospitalization for the smallest babies with the most severe chronic lung disease. Next slide. And so I've shared a little bit about DEFINE with you. I hope I've piqued your interest to the point that you would be interested in either learning more or even joining the effort. And so what are some of the next steps? You know, we're still sort of early in our journey. That being said, the units that are so far participating are all on different timelines. We have some units like our Colorado Springs Children's Hospital that are kind of rolling forward. They have their REDCap data system and access all in place, are entering baseline data and are thinking about what their interventions will look like. And others that are early in the course of just forming their teams, recognizing which which members might be essential to the group, and then garnering interest. But for you all that may not have heard of Define, here we are. We want to continue to engage additional NICUs in Colorado and the greater Rocky Mountain region. If you're interested, we could send you a business agreement if you're not part of the children's or UCH system. Once that agreement is in place, we can train your team to use REDCap and grant you access to start that baseline data collection. We perform virtual site visits to support intervention selection as well as implementation. And so really adopting both a health equity, but a quality improvement framework in providing a quality improvement education and infrastructure. And as we continue the work, and as we heard from Dr. Gillespie-Bell, it's never about just the healthcare system. We don't achieve optimal health within a health care system. And so it's really essential that we engage other Colorado organizations for broader expansion and scope. We can't do this work just in the hospital if we really want to optimize the health of our infants and their families. It's got to go beyond to our community partners as well. Next slide. So I'd like to acknowledge our Define leadership team who are listed here, particularly Emily Fawaz, who is our parent consultant. And, that's really been a core principle of this effort, that we have to be led by the families that we hope to serve, that it can't be a bunch of academicians or even just neonatologists or nurses without lived experience to lead this effort. And of course, this work could not be possible without the support of our School of Medicine section of neonatology, and now with our CPCQC support. Thank you, and I'm happy to take questions.
Thank you, Dr. Wang. We do have a few minutes and we do have some questions coming in, and I just want to acknowledge that this is the gold standard, right? Patient and provider partnerships and engagement. So kudos to those who developed the Define program and are working across the state to implement this. Our first question is for Emily. One audience member wants to know, what would have helped you during your days in the NICU? Any small adjustments?
Can you hear me?
Yes.
I don't know if I can see, if you can see my video, but I think when I've thought about this, I think one of the things, like, coming to me, if someone came to me and said, what are your unique barriers to, being present, and how could we make this experience a little bit easier for you? Because I think that, just in getting to listen to these Define groups and being involved, I think it's twofold. It's how do we on a big scale, make standardized, like you were saying, Susan, change on a big scale what we're doing in the NICUs to be more family centered, but while also recognize that each family has different things that might help them. So like I kind of mentioned, for me, if I had someone sit down with me and try to figure out a way to make my schedule work and, help me figure out my pumping schedule and cares and all that stuff so that I didn't feel as stressed every day, not knowing what time I was going to hold or what was going on. Just things like that, like coming and sitting down with me and asking those questions. I also think, I am an OT. We learned, I'm not a mental health specialist, but we talked a lot about mental health, and I feel like I'm very self-aware of my mental health. And yet looking back on that experience, I think wow, I needed a lot more help than I asked for. I don't think you even know how hard that experience is in the moment. And I think that would have helped a lot, because even though I would say, I think I'm fine, I'm coping well, it's really hard, but it's a really hard situation. So I didn't think that I had postpartum depression, and I still don't think I did. It doesn't mean that it's not this horribly traumatic experience and that I wouldn't have benefited greatly from having more support on the mental health side.
Thanks, Emily. Super important. And I know Dr. Wang has been having conversations about that and really trying to raise awareness about mental health of parents with infants in the NICU, because it's very impactful on mental health. And so it's something for us as care providers to remember and connect people with resources and support that they might need. We have another question that just came in. Dr. Wang, this is for you. Will each institution be required to get a letter from their local IRB?
Oh, I just typed in an answer, but I'm happy to
Oh, perfect.
No. First of all, hi, Dr. Pentoa, that was from him. But so we've left that up to the discretion of each individual hospital. I think there are some that feel very comfortable with our campus's IRB designation that this is not human subjects research and in fact quality improvement. And so some hospitals have decided that they don't need to approach their IRB, but we've certainly left that up to the discretion of individual hospitals. What we do require is that business associate agreement so that patient level data could be entered into our centralized data system.
Thank you. And a few comments are coming in, obviously, that this is so important, echoing, recognizing when there might be needs for mental health support. Somebody chatted in Parent Line, Colorado. There are a ton of resources, and one of our big focuses at CPCQC, and certainly working with the Maternal Mental Health Collaborative and Framework, is really to be able to ensure that people are aware of these resources and that families have information and that they're relatable stories, that, Emily, to your point, that they determine, is this normal? Am I feeling normal? Or other people experiencing this in my situation? And so there are definitely some great resources, and we can post those into the WOVA app. There's Parents Thrive Colorado, which is an amazing website that the Maternal Mental Health Collaborative and Framework has launched. It's a welcome mat to resources for parents and families, and a number of other things I see people chatting in. So we'll make sure that our team gets those resources into the WOVA app, along with the slides, the recording, and all of this information, because there are resources. And so we are here to help connect providers, patients, and families to those resources.
And I'll just add that I think in Colorado, we are perhaps more resource rich than we realize when it comes to supporting families. I think oftentimes we live in silos, depending on where we work and live, and are not aware of what may exist. And so all these resources that folks are chatting in that you, Jamie, have outlined, I bet the majority of NICUs are not aware of. That's one. The second is that we don't know there's a problem unless we ask, unless we screen. And I think universal screening for postpartum depression and anxiety of mothers and fathers is not occurring universally in NICUs. We've known for some time that for mothers, mental health conditions are certainly much higher in the preterm population than in the term population. And now we have a growing body of literature that fathers too are suffering from all of that as well. And what's interesting is that while during hospitalization, mothers of preterm infants have likely higher anxiety, maternal depression scores than fathers, after discharge, it's the fathers that then have higher scores. They flip. And so it's there's a lot more to be studied, but we've got to do a better job on identifying these mental health issues in our families.
Yeah, I appreciate that. Thank you. And, joining the collaborative and the programs, a way to get tools and resources, share the information. Dr. Wang, to your point, focusing on screening. How do we screen? What information are we looking for? And then when we identify something, the ability to diagnose and refer for treatment if needed. So lots of opportunities, lots of great education, information, tools, and resources. So we would invite you all, if you're not currently participating as individuals or hospitals, we'd invite you as birth centers, outpatient facilities. This is work that can be done by all of us and should be connected across the perinatal period. Dr. Wang, to your point, after discharge, connecting with pediatricians and family physicians, really to continue providing tools and resources to families that they need. And I see a few more chats in, Postpartum Support International, PSI. We have a local chapter here in Colorado, tons of resources, Leslie, yes, agree. So again, we'll work together. If you're an audience member and you have a resource that you refer folks to and you love, send it in. We'll compile all these together in the WOVA app and certainly start to work to really link to these on our website in the future too.
Just to add in a few snippets, thoughts with the screening, I think it's really interesting, like having been in that experience and filled out a screener, it's hard because that, you know, that the postpartum screener, when I remember answering the questions, and I know one of them is, do you find yourself worrying for no reason, like often? And I think for several of the questions on that screener, I remember thinking like, well, I don't even really know how to answer this because my kids are intubated and they had, you know, coded yesterday. So I don't think it's no reason. So I'm not worrying for no reason, but I am worrying all day, every day for them, which is still very taxing on my mental health. So I think that even with it, using those screeners are challenging for NICU families to even know how to answer them all the time. The other thing I just wanted to say real quick, so one of the organizations I'm involved with is the NICU Consortium Partnership, and right now we're working on a project, getting a website up and running that we're calling the NICU Connection, or NICU Resource Connection of Colorado, and we are doing just that, where we have been spending months trying to find the resources that exist in our state, because like you said, there are a lot of resources, and having left the NICU, learning about all these that I didn't know about, we saw that as a need to make that connection. And so we are actually working on having a standalone website connected with the Newborn Hope organization, but that parents, very user-friendly for parents to be able to find resources in the state by region and by different category of the types of support they provide. So we're excited about that as well.
Love it. Thank you so much. I just want to thank you both again for sharing such, you know, your story, Emily, so informative, your call to action, your advocacy, Dr. Wang, for all your efforts to bring patients and providers together and focus on giving support that is necessary in the NICU and beyond. It's amazing work, and I'm really looking forward to seeing what happens over the next few months and few years here in our state. It's really inspiring. So thank you both. For those in the audience, questions can keep coming. We'll get to those after the conference. If there's something you're looking for or resources, please don't be shy. We will post again the slides and the recordings in the WOVA app, and have information you can share in the community as well. So if you want to reach out to anyone you saw today, you can do that in the WOVA app. And at this time, we are going to take a half-hour break for lunch. So please step away from your computers, get some nourishments, and we'll see you back at 12:30.